A very big hello to all my dear students. So, how are you all? June has already started. Huh? Neat PG very close. Butterfly in the stomach. Huh? So, the key is keep moving, keep revising. And even if you slow down sometimes, feel tired, but don't stop. Right? Okay, so what do we have today in your T2O series, your favorite channel? Let's see. Let's read this clinical vignette together. I think this is quite obvious. The diagnosis you all can diagnose immediately. So I'm just going to discuss few points around it. It's very important topic if you think about for every exam, right? So NEET PG के लिए भी this is absolutely very important topic. We all know this. Okay, so 1-year-old child, the age is anyway significant, presents in the eye OPD with the parents complaining of white pupil of his left eye. This is left eye. So, you know, when you say white pupil, what do we mean? You're talking about leukocoria. The red reflex testing with a direct ophthalmoscope showed leukocoria in the left eye, as I just said. Left eye showed esotropia of 15 prism diopter. ESO, it's a convergence squint. Detailed examination under anesthesia was done. Every child should be examined this way. So tonometry was done, which was normal pressures in both eyes. Showed normal pressure in both eyes. Then corneal diameter was also normal. Anterior segment normal and fundus examination. Right eye is normal, but left eye showing a single large tumor at the macular area. Ultrasound showing classification within the tumor. Typical of, no, we are talking about retinoblastoma. Right? So first of all, in this, what is the most common age of presentation? It is 18 months. This patient is 1 year, right? That is one important point, right? So, and most common mode of presentation, we all know it is leukocoria, and second most common is your strabismus, which this child is presenting with. Second most common is strabismus. What happens in a small child? Generally, the medial rectus is very strong. Any non-seeing eye, any tumor at the macula means fovea is not working. So when there is a non-seeing eye where the vision is literally affected, then eye is going to turn inwards in a child. Non-seeing eye in adults, it is always turning out. Keep in mind. So that is why this child is having 15 prism diopter of esotropia because the tumor is at his macular area. We can see everything and correlate. Okay? Okay. So once we know this, a few important points for your revision. This is of course leukocoria, cute child. The left eye leukocoria, right? Another thing is very quickly, what can be the causes of leukocoria apart from retinoblastoma? It can be congenital cataract. It could be just a cyclitic membrane, which happens in anterior uveitis. It could be just a fungal endophthalmitis, which is shining white. It could be central choroiditis, like toxocoriasis, that is shining white in a child, right? Then it could just be central retinal detachments. It could be retinopathy of prematurity. It could be Coats disease, right? Retinal dysplasias and also central coloboma. Coloboma, when embryologically a part is not formed, we call it coloboma. So keep in mind, all these can be the cause of leukocoria. If they ask you most common cause, it is congenital cataract. Please, many of you say glaucoma. No, it's not. We're talking about cataract because we're talking about white eye reflex, pupillary reflex. Okay? And I hope you all know that all the causes, apart from retinoblastoma, is collectively known as pseudoglioma. Right? So these are some important points around leukocoria that you should remember. Of course, this is a tumor with a large tumor at the macular area in this patient on fundus examination. And I think recently on pathology also, the question was asked, so please remember your flexner intestinal is the true rosate with the central lumen, whereas Homer Wright will be pseudo rosate without any lumen. Or the third finding could be fluorates. So just revise all this. Right. What do you see here? This is an ultrasound B scan, and this is showing you the tumor, right? So this is the B scan showing the intraocular tumor, that is retinoblastoma. Okay, answer a few more things here. What is the most common mode of spread? So I don't know why it is debatable, but it is. Please answer through the optic nerve. Okay, and then they have another question: most common non-ocular malignancy. You are going to answer what? Non-ocular malignancy. It is osteosarcoma, right? And revise your staging of retinoblastoma, which is international classification of retinoblastoma, which divides the stage 1. It is for intraocular tumors, where it is dividing it into groups A, B, C, D, E. Okay, so I want you all to, I'm not going to take that in detail this session, but please revise it. Okay, thank you so much. Stay blessed. Do you want me to take that? Okay, because the exams are, if you want, maybe you will think, why ma'am has not taken this. Let me help you to learn what is the international classification of retinoblastoma as well. So when you talk about stage 1, which is intraocular tumor, we divide it into A, B, you learn together, C and D, you learn together, and then comes E. When you say A, it is any tumor of less than 3 millimeters, okay? And it is away from the important structures like optic nerve and macula. When you say B, it is just the opposite, that is size. We are talking about the size, which is more than 3 millimeters in size and near the optic disc or macula. Optic disc or macula. Okay, nerve knee optic disc. Okay. When you say C and D, the tumor has spread. In C, it is focal, and in D, it is diffuse. Where it has spread, we are talking about vitreous seeding and subretinal seeding. Subretinal space, you should be very clear what is subretinal space, right? Retinal pigment epithelium, neurosensory retina, between that, the space is subretinal. So when you say C, C is your, that the tumor is 3 millimeter or this away from the seeding is within 3 millimeter. We are saying within 3 millimeter, there is seeding that is called, you just write within 3 millimeter. Okay, it's easy to learn. Within 3 millimeter of the tumor, when you have the seeding, this is your C. When more than 3 millimeter away that it has spread, this is your diffuse seeding. Where is the seeding? I told you in the vitreous or subretinal. And E means a very large tumor which is occupying more than half of the eyeball. That is called E. Okay. Okay. So if it is this stage, this is all considered as stage 1, right? So if your patient is in stage A, you go for focal therapy with cryophotocoagulation. If it is going into B, C, and D, you give chemotherapy for the chemo reduction and then go for focal therapy. If it is in group E, then you have to remove the eyeball. Enucleation is done. Once you do the enucleation, you have to see whether the optic nerve is involved or not, isn't it? And if the optic nerve is involved, now it is stage 2. Okay. And what is stage 3? When it goes extraocular, means into the orbit. So extraocular extension becomes stage 3, right? So how do you manage stage 2? You have already enucleated and you are seeing that the optic nerve is involved. So rest, what you do is go for radiotherapy and chemotherapy. And in stage 3, when there is an extraocular extension, we have no other option but exenteration. And in stage 4, it is distant metastasis. And for distant metastasis, we have to just go for palliative therapy. So you go for a palliative therapy. That's how you manage retinoplasty. I think now it's good. Huh? So thank you so much. Stay blessed and keep learning. Okay. Happy learning to you all.